Welcome to the webinar. My name is Dr. Jean Marsters, and I'm the chairman of the California Society of Addiction Medicine's Committee on Education. The topic of today's webinar is Opioid Safety with Naloxone, a life-saving tool for California physicians. CSAM is an accredited provider of continued medical education, CME, and is offering 1 hour of CME credit free of charge for those who participate either live or in a recorded version of this webinar, and those who complete the brief post-webinar survey. This webinar will last about 55 minutes. After it concludes, you will receive an email with a link to a brief survey. Once you complete this survey, you will be able to print out your CME certificate. If you're having problems with the audio portion of the webinar, you can listen over your telephone by dialing 800-745-8951. This number is posted on your webinar screen. The only people who can be heard on this call, in addition to me, will be our presenters. If you wish to ask a question or you're having technical difficulties, please click on the chat box and type in your question. You can do this at any point during the presentation. After the presentation, we will answer as many questions as time allows. Now it is my pleasure to introduce our speakers. Dr. Philip Coffin is the Director of Substance Use Research at the San Francisco Department of Public Health and Assistant Clinical Professor in the HIV/AIDS Division at UCSF. He's a board-certified internal medicine and infectious disease clinician. He oversees several pharmacologic and behavioral trials that aim to reduce substance use and relevant harmful behaviors. Since the early 1990s, Dr. Coffin has been involved in developing and studying services for drug users, including syringe exchange, agonist maintenance therapy, and overdose prevention programs. Eliza Wheeler is a project manager at the Drug Overdose Prevention and Education Program, known as DOPE. This is a division of the Harm Reduction Coalition. She has master's degrees in crime and justice studies and public administration. Her work is to oversee the project's efforts to prevent overdose deaths in the San Francisco Bay Area, and she provides technical assistance throughout California and nationally to programs working to implement naloxone distribution. Please help me in welcoming Eliza Wheeler and Philip Coffin.
Thanks very much for the introduction. So this is Philip Coffin speaking. I'm going to start and go through some basics around naloxone prescription and distribution, and Eliza and I will switch back and forth. First, I'd like to thank everyone for joining the call and the webinar, and also to thank CSAM for hosting this. We've been doing naloxone distribution or prescription for lay opioid overdose reversal for nearly 20 years in the United States, and it's very exciting to be at this point. In terms of disclosures, we have no financial disclosures. We will discuss naloxone by intranasal administration, which is a route that is not yet FDA approved. So as I said, we've been working with naloxone distribution for lay opioid overdose reversal for almost 20 years. Some of the major advances have come in the form of legislation. While it has always been legal to prescribe naloxone because it is a routine prescription medication, not a controlled substance, there were originally some concerns regarding the third-party administration issues around naloxone, because the person it's being prescribed to may not be the person who's going to be administered the medication. So there have been several laws that have emerged over the past decade. In California, there was originally a 2007 law that applied to 7 counties and provided some liability protection for prescribing naloxone. As of January 1st, 2014, there's a new law which is far broader and provides many additional protections and avenues for increased naloxone availability. First, it covers the entire state. Second, it protects any healthcare professional with a license who can prescribe naloxone from any civil or criminal liability if they prescribe, dispense, or oversee distribution of naloxone via a standing order, either through their usual clinical practice or through an overdose prevention program. It permits individuals to possess and administer naloxone in a suspected overdose and protects those individuals from civil or criminal prosecution for practicing medicine without a license. And importantly, it really clarifies and emphasizes that prescribers are strongly encouraged to prescribe naloxone to patients on opioid medications in order to address the prescription drug overdose epidemic. So basically, this law means that as a prescriber, you may prescribe naloxone to anyone you suspect may witness or experience an opioid overdose, and that person may possess it and use it in a suspected opioid overdose without any concerns about civil or criminal liability. It also means that a prescriber may issue a standing order for naloxone to be dispensed in an opioid overdose prevention program by non-medical personnel who provide some degree of training around opioid overdose prevention and management. So, as you all know, naloxone is a short-acting opioid antagonist. It lasts about 30 to up to 90 minutes. It's very, very specific to the mu-opioid receptor and has a very high affinity for that receptor. The only opioids that have anywhere near as high affinity are fentanyl and buprenorphine, and naloxone still has a higher affinity than those agents. It's the only element in the coma cocktail that can be safely administered by itself. So the coma cocktail is glucose, thiamine, and naloxone. It's what's administered if somebody is in a coma, unresponsive, and you have no other information about them. The glucose can't be administered alone because if this person happens to be a thiamine-deficient alcoholic, you may precipitate Wernicke's encephalopathy. So naloxone is the only agent that you can safely administer alone. The only known contraindication to naloxone is an allergy, and I have never heard of one or seen one in the literature. The opioid withdrawal symptoms that you see with lay-administered naloxone are generally quite mild. This is largely due to the doses that we use and the routes of administration, which allow for a more mild onset and offset of the naloxone effect, but also because lay naloxone is generally administered by friends or family or acquaintances and is not in the tense, less often in the tense setting of paramedics and police surrounding a drug-using scene. The opioid effect will return. This is really a concern mostly for the long-acting opioids. The data around heroin overdose strongly suggest that it's very, very rare for somebody to have a recurrent heroin overdose that results in death. There are several studies that have looked at it with N's over 10,000, and the risk of a recurrent overdose resulting in death from heroin if naloxone is administered and then the person is released from care is probably less than 1 in 10,000. However, with long-acting opioids, this is more of a concern, so I like to think of naloxone as more of a stopgap measure until care can be sought. The effects of naloxone, if there are no opioids present, are essentially nothing. There can be a little bit of a headache. There are some mild side effects that you can get from large doses of naloxone, but there's essentially no effect whatsoever. So briefly on the concept of lay naloxone, and I want to preface this by saying that the construct for lay-administered naloxone was initially designed for heroin users, and so the data is mostly based on heroin users. There has been growing data with prescription opioid users, but it is a much weaker data set, and there are some parallels, but there are also some differences. So we know heroin overdoses are usually witnessed at least 85% of the time. We know that death takes a long time. The pathophysiology of opioid overdose is actually quite fascinating and involves a slowly rising carbon dioxide and cognitive dysfunction from hypercarbia, such that eventually people cannot respond even to deep stimulation and require other interventions like naloxone. We know that emergency medical services are not routinely accessed, and that about 50% of people who witness an overdose call emergency medical services. That number is a little bit higher if the person has never witnessed an OD before. It's lower if the person has witnessed multiple events previously. This is akin to if your child had their 20th asthma attack, you probably wouldn't take them to the emergency department because you'd feel more comfortable managing it on your own. We know that naloxone is very safe and very effective at opioid overdose reversal, and we know that the more rapidly you get naloxone on board, the less likely you seem to be to require advanced respiratory support such as BiPAP or intubation. There is also the suggestion, and I will say that this we don't have solid data on this yet, but of a possible behavior change in the setting of naloxone distribution. This comes from some earlier data that suggested that the prospectively followed naloxone recipients and found that they reduced their heroin use after receiving naloxone. More recent qualitative data that suggests that naloxone recipients have a increased sense of empowerment and sense of responsibility when they carry naloxone. The experience in clinics that have dispensed naloxone has been remarkable in some settings, such as U.S. Army Fort Bragg in North Carolina, where they started giving naloxone to pain patients, and they went from 8 overdoses a month in the emergency department and 12 deaths a year to 0 events and 0 reported reversals, which is obviously not explained by naloxone being used to reverse an overdose event, but suggests that naloxone may have played a role in some shift in the way that opioids were used among those patients. Also, in the ecologic data, we've seen overdose death reductions around 30 to 90% in the setting of naloxone distribution. And that is a dramatic reduction that would be very hard to attribute to naloxone, particularly if the only thing naloxone does is reverse overdoses, if it has no behavioral impact. We completed a mathematical model that was published in Annals of Internal Medicine in 2013, in which if we determined if naloxone is only used to reverse overdose death, we should expect to see around 5 to 10% reductions in mortality in a given community. So in order to get the model to allow for such dramatic reductions as 30% or more, we had to assume that naloxone actually reduces overdose risk behavior itself. There are some studies explicitly looking into this, but the results won't be out for several years. In terms of mortality reduction, the best data we have are out of Massachusetts, where they completed an interrupted time series analysis of 17 communities that did or did not distribute naloxone. The adjusted risk ratio for mortality was 0.73 among those communities that had a low level of distribution of naloxone, and 0.54 in those communities that had a high level of distribution of naloxone, suggesting the possibility that the more naloxone we get out into a community, the less opioid overdose mortality we may witness. Eliza's going to take over here.
Hi, everyone. Thank you, Philip. So this slide is looking specifically at the work that's been done in San Francisco. The project, the Drug Overdose Prevention Education Project, which is funded by the San Francisco Department of Public Health, has been distributing naloxone to primarily heroin users since 2003. In San Francisco, what we've seen is a dramatic decrease in heroin overdose deaths from around 99-2000 to the present. So we were looking at upwards of 120 heroin overdose deaths around the years 1999-2000, and now we're experiencing under 20 per year for the last few years. When you look at the pink part of the slide is the heroin overdose deaths, and then the blue parts of the slide are the work that has been done by the DOPE Project, which you'll notice the dark blue line is new people that have been enrolled and trained how to use naloxone at our sites. The next lighter blue line is the number of refills, so that's people who have returned to get a new naloxone kit who have been previously trained. And then the final turquoise line is the number of reversals reported to us each year. So what that means is that someone uses their naloxone to reverse an overdose out in the community and then comes back to tell us about it. For the past 2 years, 2012, 2013, we've received almost an identical number of reversal reports, around 275 per year. So we're seeing almost 300 overdose reversals by drug users in the community per year, suggesting that heroin overdoses are still occurring, but people aren't dying. Just a brief overview of what's happening nationally in terms of opioid overdose prevention and opioid safety programs. The CDC published a paper in 2012 which summarized a national survey of community-based naloxone distribution programs, which were primarily located in syringe exchange programs and distributing naloxone to drug users in the community. What that paper showed was that between 1996, when the first community-based naloxone program began distributing naloxone, up until 2010, the year of the survey, over 50,000 drug users and some of their friends and family were trained on how to use naloxone, resulting in over 10,000 reversals reported back to the programs. Currently, as of 2013, there are now around 60 programs distributing or prescribing naloxone in the U.S. with about 240 individual sites. And what that means is that programs like the Massachusetts statewide naloxone distribution program overseen by the health department there may have 12 to 15 different sites but are considered one program. That's how those numbers are broken down. And we're now seeing naloxone distribution happening in around 18 U.S. states. In 2012, about almost half, 55% of the naloxone distributed in community-based settings was injectable, and 45% was the naloxone adapted to be administered intranasally. To echo a little bit about what Philip was talking about in terms of the California law, this can be interpreted in several different ways in terms of how to provide access to naloxone in the community. The first is that the prescriber can write a prescription and the patient can then fill the prescription at a pharmacy. This model, in terms of interpreting the new California law, will work best in a clinic or hospital setting with insured patients. The pharmacy will need to be worked with around setting up the ability to fill an outpatient naloxone prescription. Philip's going to talk a little bit about that in the next few slides. The next model could be that the prescriber writes the prescription but directly dispenses the pre-assembled naloxone kit. Again, Philip will touch on this a bit. And then the way that our program operates and that community-based programs often operate is where a prescriber writes a non-patient specific standing order for a community-based program or treatment program. And then the program staff provide the education and distribute the pre-assembled kits. This is a great model for community-based programs that are reaching folks that may not be engaged in medical care with a provider. Just a little bit about what a standing order is. On the bottom of this slide, you'll see a link to our website where you can look at an example of the standing order used by the San Francisco Department of Public Health for our project here. Standing orders are used to allow naloxone access here in San Francisco, in the state of Massachusetts, and now in North Carolina, Illinois, and a few other cities and states. this model is really used to facilitate wide distribution of naloxone to people who are potentially disconnected from a healthcare system. There's a few things that those standing orders include, including a reference to whatever authority allows the issuing of the standing order, in our case, California Law AB 635, a little bit about what product is that is being dispensed, and the protocol for dispensing, who dispenses and who's ordering, which would be the prescriber. There are no predetermined guidelines as to what the standing order includes that are included in the legislation, but the standing orders that we use here in San Francisco are modeled after the Massachusetts system that's been in place since 2006.
So in terms of when you're prescribing naloxone, there are two formulations that are generally considered. The first is injectable, and this is a vial of 0.4 milligrams per 1 ml. We generally recommend intramuscular administration. Subcutaneous or intravenous is possible as well, but IM is, I think, the most simple one to demonstrate to patients and easiest to perform properly. The basic script information is on this slide, and you also need to include intramuscular syringes. The intranasal, which is off-label, is a pre-filled syringe device, a needleless pre-filled syringe of 2 milligrams per 2 mLs of naloxone. 1/2 is sprayed into each nostril, and that also requires a mucosal atomization device. It's a nasal adapter. This is access for pharmacies is complicated because it's not a drug. It's not available through their usual drug distributor contracts. Pharmacies would need to have a new contract with a medical device distributor. There are efforts to improve and streamline this process and make the MAD device more available in pharmacies, more readily available in pharmacies, but that is still tricky at this time. As we discussed, the recipient does not need to be the person to whom the naloxone is administered, and there are SBIRT codes that cover naloxone and overdose education in 15-minute intervals for Medicare, Medi-Cal, and commercial insurance. So when you're working with a pharmacy, I would recommend contacting the pharmacy prior to prescribing naloxone, because naloxone is new for the pharmacist. There isn't a patient education printout that they have on their computers. So what we have done is contact pharmacies generally about a week or so before we anticipate a prescription. If you do it too far in advance, then the pharmacists forget everything by the time it's prescribed. So they're really only interested once they get a prescription, but you want to give them some education beforehand, a handout, some basic information, something so that they know what kind of education they should be giving to patients. And you can give them the basic information on how to order it. So the NDC numbers are important. The intranasal, what we call the intranasal, the 2 milligrams per 2 mLs, there is we prescribe the needleless version. There is a similar one with a different NDC code that has a needle on the pre-filled syringe, and I haven't figured out what that is intended for, but it's not what you want to prescribe. So the NDC numbers are important to share with pharmacists. The MAD device, the atomizer device, is can be ordered through distributors, medical device distributors. Although in many cases it's easier just to directly give patients those devices. They have no expiration date. The counseling that we recommend for pharmacists to give to patients is pretty basic. Just instruct the patients on to administer if a person is non-responsive from opioid use, and to make sure they know how to assemble the kit. And then also to make sure that either a caregiver is present, or that the patient knows to inform a caregiver about where their naloxone is, how and when to use it. Naloxone is covered by Medi-Cal. It's covered as a carve-out, so the pharmacist has to submit directly to the fee-for-service Medi-Cal. They should not send this to the local HMO plan, because they're just going to say you need a prior authorization, which is not the case. It is also covered by many Medicare Part Ds and some commercial insurance. The the mucosal atomizer device, because it doesn't have a drug code, requires a treatment authorization request, which is something that pharmacists complete. It's pro forma. There's a 24-hour turnaround. The issue with this is that there's a very small profit margin, so there's not a lot of incentive for pharmacists to complete this paperwork in order to get reimbursed for the device. So you might be able to find a pharmacist who's really committed to this issue, willing to get this contract, or already has a contract with a medical device supplier, and can come up with an easy way to do this turnaround. But most pharmacists at this very moment in time are not going to have easy access to the nasal atomizer. So in the San Francisco setting, where we had such a reduction in heroin overdose mortality, we had an increase in prescription opioid overdose mortality. And we also found that many of these people who died from opioid overdose were in safety net primary care medical care and were receiving chronic opioid therapy. So we initiated a program of prescribing naloxone from primary care clinics. And one key piece of this was we stopped saying the word overdose, which we've said a lot already on this webinar, because it's a very challenging word to replace. We don't have a great replacement for it, but we do know that prescription opioid users, whether they're former heroin users or they've never used illicit drugs in their life, none of them perceive themselves at risk of what we term as an overdose. So we talk about opioid safety and medication safety, saying things like opioids can sometimes slow or even stop your breathing and may even result in death, particularly if you get more than your body is able to tolerate at that given moment, whether it's because you have an underlying pneumonia, or you had a glass of wine, or your dose changed, or somebody else gets a hold of your opioids and has an overdose event. So we actually recommend this for everyone who is on opioid medications chronically without regard to any risk assessment, because we think about prescribing naloxone for risky drugs, not risky patients. And we've had patients whose opioids have been stolen and their naloxone was stolen with their opioids. So in that setting, the naloxone went where the opioids went, which is a relatively good outcome in an unfortunate event. And we've also had patients who have been reversed with naloxone by paramedics multiple times a month for extended periods while they're taking their prescribed opioids as prescribed, and denied ever having an overdose event. So they really don't perceive this as an overdose. So we use different terminology. We call naloxone an antidote to the opioids if you have a bad reaction and can't be woken up, and we refer to it as something like an EpiPen for someone with an allergy.
So to pick up from where Philip just left off around what does the education look like when you are prescribing naloxone or providing naloxone via a community-based program. So according to the law, so AB 635, for prescribers directly providing access to naloxone to a patient, there is no prescribed educational requirement in the law. The idea was that someone prescribing a drug, there's already a minimum standard of care for prescribing a drug, and that would be to make sure that the patient knows the basics of what the drug is, when to administer it, how to administer it, and to alert others about the medication and how to use it. In terms of overdose prevention programs who are operating under a standing order, we are required by the law to provide education to the person receiving the naloxone kit. And that education is also not the components aren't specifically identified in the law, but the general education that we provide to everyone that receives naloxone is around opioid overdose risk factors, and then recognizing and responding to an overdose, how to make sure that we know the signs and symptoms of overdose, and then the steps to take when someone is overdosing. So our trainings in the community setting usually include talking about providing stimulation, calling 911, administering naloxone, and performing rescue breathing and or chest compressions, and also staying with the person until 911 arrives or until the naloxone takes effect. So looking at the two types of kits, I see some questions, a lot of questions already popping up about the differences between the IM and the IN, intramuscular or intranasal naloxone, and also about cost. I think that cost is a tough question for us to answer because there's so many factors that contribute to the cost of naloxone, whether you are getting 340B pricing or ordering through pharmacy. And so public retail costs for these products, so not taking into account different ways of billing or different ways of purchasing, but if you were just going to look up naloxone and the MADs on the internet and see the price, the form of naloxone used for intranasal, a kit with 2 doses plus 2 MADs would be around $50. And an intramuscular kit with the injectable naloxone, including 2 syringes and 2 vials, would come up to about $70, around there. So that, again, being said, does not take into account different price agreements and pricing schemes that can be arranged depending on how you're prescribing the drug. So the MADs themselves cost around between $4 and $5 a piece at this point from the company. So just to look at the 2 forms of naloxone, the intramuscular naloxone is provided usually 2 vials, 2 intramuscular syringes, with some education around how to provide the injection. The intranasal kit is provided with the 2 MADs and the 2 doses of naloxone. In terms of different preferences, a lot of people without a history of injection or a discomfort around injection might prefer the intranasal route of administration. But even when in settings where people are offered both, our program offers both the injectable and the nasal naloxone, and we have about a 50-50 sort of preference for the injectable versus nasal, even among non-injectors. So just looking at a little bit around funding, we talked about, Philip already mentioned that naloxone is billable to select insurances, including Medi-Cal, many Part D programs. The ways that community-based programs function is usually through funding and from a health department or other entity, or using private funding or foundation funding. The San Francisco Department of Public Health has funded our project for many years using general fund and now some SAMHSA SAPT HIV set-aside funds. SAMHSA released a statement last year that HIV set-aside money can be used for overdose prevention under the outreach to out-of-treatment injection drug users. So can people hear the audio? I feel like there's some comments about the audio being lost.
Why don't you keep going, Eliza?
Okay.
Because some people who are called in can certainly hear.
Okay, great. So just to sort of wrap up and then begin taking questions, we have a few resource pages here that much of the information that we've talked about today can be found, and even more. So if people are interested in implementing a community-based naloxone distribution program, probably the best resource is the implementation manual and appendices and case studies that are available at onharmreduction.org under Tools and Best Practices. There's also a great new resource on the AHRQ website, which is the U.S. Department of Health and Human Services, a comprehensive description of the Massachusetts naloxone program that's been so successful. Prescribe to Prevent is a great resource for prescribers. It's got pictures of the different ways that you can write a prescription and the different scripts. StopOverdose.org has an excellent page on pharmacy access and also how to sort of arrange for the stocking and dispensing of naloxone via a pharmacy. There's some advocacy materials on the Reach For Me site, and Philip and others provide a great, constant, updated roundup of new research around overdose on OverdosePreventionAlliance.org. If you are talking to someone who's received naloxone or is interested, there are a bunch of great training videos and resources online. There's also a search function nationally on the OverdosePreventionAlliance.org blog where you can search for the closest naloxone distribution program to where you are, and that's national. And then finally, we get a lot of contacts from families who are either looking to advocate for drug policy change or access to services such as overdose prevention and naloxone, and also some support either around grief or around having a family member who's currently using a few of the programs or support groups that we love to refer people to are Learn to Cope, which is Massachusetts-based but has an online discussion forum. GRASP, which is a support group for people grieving the loss of someone from substances. Broken No More, which is this advocacy branch of GRASP that does some drug policy work and is mostly comprised of parents who have lost folks to overdose. And then, of course, there's 12-step options, of course, for family support. Finally, the wonderful folks at CSAM have organized all these resources onto a naloxone resource page. And there are also 3 short videos that Philip and I worked on with the CSAM people before this webinar around just some scripts around talking to patients about naloxone in a primary care or in a drug treatment setting, sort of how to integrate naloxone into that, into a potentially abstinence-based setting. There's also a 3rd video that shows all of the nuts and bolts of the actual naloxone kit, so what all the devices and the drug looks like, and sort of pick it apart and show you those details. So finally, just to summarize, the California state law now permits and encourages prescribers to prescribe naloxone to people at risk of experiencing or witnessing an overdose. It encourages and allows prescribers to issue standing orders to overdose prevention programs under which that program staff may distribute naloxone to at-risk people. Naloxone recipients to administer naloxone and to others in the case of suspected overdose. The other takeaways from today is that the education component can be brief or more detailed, and the expert codes are available for billing for that education. Naloxone is covered by Medi-Cal. Pharmacies may need guidance on dispensing and may not yet be able to access the atomizer, and that naloxone access for lay persons is an evidence-based intervention that reduces mortality from overdose.
So
Thank you very much, Eliza and Philip. Let's move on to a question and answer period. I want to remind everyone signed in that you can pose questions to Dr. Coffin and Ms. Wheeler by clicking on the chat link and typing in your question. Before we move on to this period, I would like to make an announcement that after we finish this webinar, you will receive an email link, which is the CME survey, as well as a few questions. You need to fill these out in order to get your free 1 hour of CME. There will also be a link to the naloxone resource page that CSAM has put together, including the videos that Eliza just mentioned. All right, go ahead, Eliza and Philip.
So there were several questions which we've noted. A couple of them are around implementing naloxone in treatment centers, and that's part of what this is. That's part of what's so exciting about this webinar and this work and CSAM's work on this issue. There haven't been a lot of treatment centers that have implemented naloxone. There have been some. I don't know if there are any in California. The biggest message that I've seen from treatment centers is to really involve the staff in designing the program. If it's sort of thrust upon a treatment staff, you might get an experience where staff feel like it is in conflict with the abstinence-oriented nature of the treatment services. This is, I feel strongly that it really isn't in conflict. It certainly doesn't need to be in conflict with an abstinence-oriented approach. And in fact, it is critical in that approach given how much relapse we know there is and the risk of overdose at the termination of any opioid use disorder treatment program, whether agonist maintenance or abstinence-based. So involving the staff means involving them and helping them, allowing them to participate in how the program's designed, how materials are designed or redesigned for a treatment program in order to be in concordance with the underlying philosophy of the program.
I would also like to say, in answer to the question around residential treatment centers, so we have one program that just started recently outside the Bay Area, just started prescribing naloxone to their patients. It's a treatment center that does outpatient buprenorphine. There's also a lot of precedents in New York. A lot of treatment programs have implemented naloxone in New York and in Massachusetts. So there's definitely some precedent. I would take a look at the link that we talked about with the implementation manual on the harmreduction.org website, and there are some sample protocols from different programs up there to take a look at what other folks have done and to see how other treatment programs have integrated overdose prevention.
A related question was, do you recommend giving naloxone to people on opioid maintenance treatment with Suboxone who either have or haven't used heroin previously? My answer is a strong yes, and the reasons are, again, the relapse risk is real with all of these therapies. And also, the people who are on these therapies frequently have contact with other opioid-using individuals. The reversals that we've seen among our Suboxone patients are always, they've all, so far at least, they've all been reversals of that person reversing somebody else with their naloxone, which makes it a very valuable intervention, and I think may also contribute to a feeling of empowerment, responsibility, and success for patients in those treatment programs.
Someone asked if the individual needs to be breathing in order for the intranasal form to be effective, and the answer is no. We're operating on the assumption that the person is not breathing or barely breathing when it's administered, and it actually just absorbs into the mucosa. And so it's not an inhalation, so it doesn't matter if they're not breathing.
In terms of prescribed naloxone from clinics, we haven't run into any issues with copays at this time. Certainly people can pay out of pocket for it. I haven't heard of any issues with copays under Medi-Cal. The other people receiving naloxone in our setting are the otherwise uninsured individuals who are on Healthy San Francisco, which is a safety net coverage plan for patients that have too much income for Medi-Cal in San Francisco.
There's a question here. Is there any information available for the experience of an OTP providing this in California? How and where are the kits stored, costs, training, etc.? So there's a few Well, so to answer the question is, our project in San Francisco provides some naloxone distribution at an OTP in the city in San Francisco. It's not done internally in-house at that OTP. We actually go there and do the training for the patients on that methadone clinic. But there is some direct pharmacy dispensing of naloxone through the CBHS, which is the Community Behavioral Health Services program, which is part of SFDPH, and they dispense naloxone via the pharmacy to anyone that's coming to fill prescriptions for buprenorphine. So there is definitely some precedence, and then again, that other program that I discussed that just started dispensing naloxone out of their OTP outpatient program in Contra Costa County. So I would, let's see, I'm not sure how the best way to get in touch with those programs via us. Maybe send an email to CSAM and we can connect programs that are want to look at what other people's protocols are, if it's not already listed on any of the sites that Philip and I mentioned.
There's a question here about modeling of naloxone for prescription opioid patients. I haven't completed formal modeling of that. In informal level, the basic assumptions hold, although the rates of overdose among prescription opioid recipients are much lower than heroin users. The rough estimate is that heroin users overdose about 15% overdose per year on average. There's a great variation. There are people who overdose much more frequently, and there are people who don't overdose at all. And the mortality rate from heroin overdose has historically been estimated at 1% per year. For prescription opioid users, it's challenging because studies vary so much on how that population is defined. In general, the overdose risk is probably under 1% per year, and the mortality risk is about 0.2% per year. So the overdoses are more likely to be fatal. Prescription opioid overdoses might be less likely to be witnessed. So there are various differences on an event level between prescription opioid overdoses and heroin overdoses, and that varies a lot because the population of prescription opioid recipients is so diverse, even more diverse probably than the population of heroin injectors. Overall, I would say that the basic outcomes from the model hold, although the relative cost effectiveness is going to be a log different, one to two logs different.
So, Philip, I'd like to just a question about that, Philip, is when you say prescription opioid users, do you mean people who could be getting it in pain clinics or off the streets?
That's exactly right. The way prescription opioid users are defined in these studies, sometimes they're looking at just non-medical users, sometimes they're looking at recipients, sometimes they're looking at people more than a certain dose. So sometimes there are risk factors built into the analyses and other times there aren't. So how you carve up that population is going to affect your outcomes quite a bit.
I just wanted to get to we have about, I think, 7 more questions and only 6 more minutes. So one question was the California law addresses addiction. Are pain clinics similarly covered? The law actually doesn't address addiction at all. It's simply a law that's addressing the mechanism for prescribing naloxone or distributing naloxone, and it doesn't differentiate between whether people are quote addicted or not addicted or receiving pain medications. It's about opioid overdose, so that could include medications that people are receiving via prescription, or it could include street-based pharmaceutical purchases or heroin use. So the law is really about just liability protections for the prescribers and the programs and the users of naloxone.
There was a question about the efficacy differences between sub-Q and intramuscular, and there was also a question about if the intranasal form is off-label, why prescribe that instead of intramuscular. So we generally recommend intramuscular or intranasal, and the reasons are intravenous, obviously, it takes too long, and we generally don't encourage lay intravenous administration of medications, especially in emergency settings. Even though a lot of heroin users are, frankly, more comfortable giving naloxone intravenously. The subcutaneous administration, I think, is actually still more complicated because you might end up with an intradermal administration instead of a subcutaneous administration. So I personally think that intramuscular is it's the easiest to demonstrate, it's the easiest to teach, it's the easiest way to administer it. Subcutaneous, if done correctly, is very, very similar in terms of efficacy to intramuscular. The intranasal administration emerged. We started doing that around 7 or 8 years ago, and that was in part because people, perhaps providers more than patients, aren't comfortable with needles. So there may be concerns about needles leading to relapse. Some people might have those concerns. I don't know if there's any validity there. And providers in general might be less comfortable giving people needles, especially if they're giving out kits in clinic. They might be less comfortable having needles on site. I ran a hospital program of naloxone distribution at one point, and having needles in the kits that we were giving to patients made nursing staff very uncomfortable. So the intranasal route of administration was a far more palatable approach for that population. In addition, when you're giving the kit, when you're giving naloxone to somebody, you might be giving it to their family and caregiver as well, effectively. So you want to make sure it's something that they might be comfortable administering. Of course, the intranasal kit is more complicated. It's harder to put together. So it is harder to administer, but doesn't engender the same concerns that needles tend to.
To very quickly answer the question about how we fund distribution in San Francisco, there was a mention of that on one of the slides. We're funded by the Community Behavioral Health Services. We get general fund money, and we get SAMHSA HIV set-aside money to distribute naloxone kits. We distribute those for free to people.
In clinics, there's a question on the process of implementing naloxone prescribing in clinics. Who gives the training? Are kits given out by clinics or pharmacy? And feedback on provider trainings. So providers are generally very comfortable doing this. The prescribers generally want somebody else to do it. They'd love it if the pharmacist could do it, or if an MEA or nurse could do the basic teaching, because it does kind of take probably 5 to 10 minutes. You want to ideally demonstrate the kit, especially if it's intranasal. So the provider, in the ideal setting, I think the prescriber discusses it and gets and sends the prescription to the pharmacy. The nurse or MEA gives the atomizers and a brochure to the patient and uses a demonstration kit to show how it's put together, make sure they have all the information. They pick up the medication at the pharmacy and put it in the bag with the atomizers and the brochure. That's the way we've structured it in San Francisco.
You know, we're going to have to bring this webinar to a conclusion. On behalf of the California Society of Addiction Medicine, I'd like to sincerely thank our 2 speakers, and also thank all of those of you who participated in the live portion of our webinar today. This is a reminder that a recorded version of this webinar in its entirety, along with free CME, will be posted on the CSAM website starting tomorrow. If you have enjoyed this presentation, please encourage your friends who you think would benefit from it to log in and participate in the recorded version. After this webinar concludes, you will be receiving an email that will have the CME survey, which you must complete to get your CME credit for this activity. The link will also include links to video presentations that our speakers have recorded for your benefit in how to bring up this topic with patients in various clinical settings, as well as instructions on how to assemble the kits and how to get them ready to actually administer. I'd like to remind you all that if you'd like to attend one of CSAM's in-person meetings, our yearly meeting this year, the Addiction Medicine Review Course, will take place in Anaheim, California, September 3rd through 6th, 2014. Thank you so much for participating. Again, thank you to Philip and Eliza. This concludes our webinar. Thank you all very much.